base Salerno, which is in Khost, Afghanistan. I've been here for about 6 months, since November of last year, and I'm an active SAGES member, a laparoendoscopic surgeon from San Antonio. As you see on the disclosure slide, which hopefully should be up, I have no disclosures to make, and the Department of Defense does not take responsibility for the things I may say. These would be my own opinions. Moving to the next slide, I'm going to kind of compare two deployments. One 2 years ago in Iraq, where we had laparoscopy and used it as well as flexible endoscopy, and now at a very small forward operating base in Afghanistan, where we don't, and kind of compare and contrast the two deployments. And I really enjoyed the presentation just now, and it makes me relish the idea of getting back home and getting a laparoscope in my hand. Next slide, slide number 3, shows a picture of the Balad Air Force Theater Hospital in Balad, Iraq. You just heard some of the cases from there. And in central Iraq, it's a large multi-specialty facility, the source of a good deal of publicity and publications, both from the Iraq theater. And then slide 4, I'm currently in Khost province, eastern Afghanistan, a beautiful place in the mountains, the Hindu Kush, just a few miles from the Pakistan border. Moving on to the next slide, just comparing the operative experience between the two deployments. In Iraq, over 4 months, I did about 250 cases on U.S. coalition and local national patients. We had laparoscopy and flexible endoscopy there, and but this was an all U.S. hospital, U.S. personnel manning it, and surgeons working there. This year in Afghanistan, done about 230 cases over 6 months, also operating on U.S. Coalition troops and local nationals. We don't have any laparoscopy or flexible GI endoscopy here. We do have a somewhat working bronchoscope for the occasionally very ill patient. We do have local physicians who work with us here. We have a mentorship program that we're engaged in with them, and a couple of them are staying here at any given time, working with us and learning. Next slide shows some of the capabilities of the theater hospital in Iraq. This is what we call a level 3 facility, 60 beds in it, 4 operating rooms, which can expand to a total of 8 cases going concurrently if the need arose. We had 7 general surgeons there at the time with a full array of subspecialty services. And the picture you see is 2 cases in progress at once during a mass casualty there in Balad. The next slide kind of compares the capabilities here of the FOB hospital in Afghanistan. This is a level 2 hospital where we have 8 beds. We can expand 16 plus if need be. We have 1 OR with 2 beds in it. We're staffed with 2 general surgeons, 1 orthopedist, and an internist. Moving on to the next slide, that just shows a picture of the operating room here at FOB Salerno with a laparotomy in progress, and very modern equipment, just a small hospital with very limited holding capacity. All right, next slide. Just to compare some of the cases that we've been able to do here compared with Iraq, both places U.S. troops comprised about 10% of our cases. Now, they were probably more in numbers than that, but we would usually only operate on most of our U.S. troops once, and they would be air evac'd out of theater, versus our coalition or Afghan or Iraqi patients that we would essentially own until they were better. In Iraq, we didn't consistently record the patient's service affiliation, if they were civilian or if they were in the Iraqi National Guard. But as you see there, we were able to do about 10% of our cases laparoendoscopically, whether it's doing PEGs or EGDs or laparoscopic APIs, cholecystectomies, or even inguinal hernia repairs. In Afghanistan, it's fairly carefully recorded what each patient's affiliation are, and as you see, about 40% of them are local civilians, either wounded by our forces or just involved as bystanders in conflict. About 40% Afghan uniformed services and about 6% enemy combatant cases. And again, here we don't have laparoscopy or flexible endoscopy. And 10% in Iraq may seem like a very low number for laparoscopic cases, but remember, this is a very heavy trauma population, so don't hold that against us. looks at how many of those cases we have in Afghanistan here could have done laparoscopically had I the capability. Really, again, it's about 8 to 10% could have been done that way. Appendectomies, for instance, in U.S. troops, cholecystectomy, video-assisted thoracoscopy, and a limited role for abdominal trauma. For instance, we got one patient with a real small fracture, sigmoid colon, as his only abdominal injury, which could have been easily oversewn laparoscopically. The next slide, slide 11, raises the question. So laparoscopy in wartime, what's the utility of this? Well, I think at a large theater hospital like they have in Bagram or Balad, this is potentially worth the investment and the amount of time spent there to do that. Here, for 40 cases a year at a small forward operating base, it's questionable whether that would be that useful. And then equipment maintenance. You thought your reps got paid a lot back home to service the equipment. Imagine paying them to come and do that in a combat zone. It doesn't happen. So that's all up to the hospital staff to maintain that equipment. And then our role as mentors in this healthcare system. If you look at the situation in Iraq versus Afghanistan, they had a functioning government with infrastructure and healthcare right up until 2002, versus Afghanistan without any sort of lasting legitimate government or infrastructure for probably 30 years. So hopefully in 5 or 10 years, maybe they'll have laparoscopy widespread through this region of the country. But right here and right now in this forward operating base, probably it's best that we just review the basics of surgical care with some of the local physicians that we get to mentor. Moving along to the next slide, slide 12, I'd like to put a plug in and give some credit to the World Health Organization, who have an excellent emergency essential surgical care toolkit available. You can download this for free on the internet or purchase a copy, but it just gives the basics for a country like this, who are really trying to stand up their healthcare system, of what the practical first, second, third steps are for standing up a healthcare system. Moving along to slide 13, this is a picture of myself and Dr. Nancy Taft taking 2 of our local surgeons through a bilateral opening inguinal hernia repair. And so, although it pains me not to have held a laparoscope for 6 months, this is the future for now of this country's healthcare system. I'd like to finish with just a few of our patients' stories. One of our patients came to us in clinic and told us he was extremely grateful for the measures we went to try to salvage a mangled extremity that he had, because the word on the street before he came to our hospital was that the American doctors like to cut your arms and legs off just for practice. And when he came here and found sort of the compassionate care that was offered, and the fact that we didn't just amputate patients' limbs on a whim, it really made a strong impression on him. And when people go home to convalesce in this country, they are visited by all their friends and neighbors in their home, and they get to tell their story, their account of their healthcare encounter. We had a patient just last week who was a member, actually the tribe elder of his tribe, who had a complex tibia fracture. My orthopedic partner, Chris Lindbergh, did an ORAF of his tibia. We swung a gastrocnemius flap over to cover that with some soft tissue and put a skin graft on, and this fellow went home doing great, having a leg where he would have gotten an amputation at one of the local hospitals. The first day he was home, 600 people came to visit him at his house. The second day he was at home, they estimated probably 1,100 to 1,500 people came to visit him at his house. And so that's the kind of lasting impact that we hope to have, treating people with compassion and kindness, I think, in this country, helping to stand up their healthcare system by mentoring and just rendering good care as best we know how in this situation. So I'd like to thank you for the opportunity to present. My next slide just has a few thanks to various people. I'd like to thank the program committee, SP Bowers. Appreciate you organizing this event. I'd like to thank some of our partners here at FOB Salerno and the commander of the hospital. Alan Chips is the brains behind all the AV wizardry going on here today. I would like to thank the folks from SAGES and some of our local physicians that are partnered here with us today. And I'd be happy to take any questions that the audience may have. Thank you.
Thank you very much, Josh. We'll go ahead and ask questions of Josh now because he'll have to sign off when Dr. Brisbois is on. Josh, I have a question for you. It sounds like the need or the appropriate use of laparoscopy and minimally invasive surgery on the host nationals may be more dependent on the quality of care in that nation, particularly when we're trying to instruct the host nation surgeons. Does that sound accurate to you? Can you elaborate on that?
Yeah, I totally agree, SP. I think that you really need to crawl before you can walk. And right now, this healthcare system, the basics that we're trying to teach the physicians is how do you fix an inguinal hernia open? What's the anatomy? How do you properly glove, gown, and maintain sterile technique? How do you write orders on the ward? They say that the local hospitals, the physicians here, will not write any orders. They'll just expect the nurses to do the right thing and berate them if they don't. So it's really starting with the basics. How do you write admission orders? How do you manage an open fracture? You don't close the wounds up right away. You wash them out until they're clean, and those sorts of things. So I hope soon laparoscopy will be part of the picture here, but right now it's the basics really.
Thank you. There's a question from Dr. Schweitzberg.
Josh, Steve Schweitzberg, I'm the current SAGES program committee, and we're thrilled to be doing this. And I'm also a Desert Storm veteran. Can you tell us how often you're frustrated because you have a wounded soldier or local and you just don't have the tools, the mesh, the suture, or whatever you need to do to take even just basic care, not to mention fancy care, is out of the question?
Thank you, Dr. Schweisberg, for the question, and thank you for your service in Desert Storm. Usually with the U.S. troops, our role is mainly one of stabilization and transfer, and so I often have all the tools that I need to do that. Many times then we're left doing definitive care for local uniform services like the Afghan National Army or Afghan Border Police, and we sometimes have just the supply chains are a little bit slow and cumbersome in getting the tibial nails, whatever, the BioBrain, the various accoutrements of trauma that we need. But not too often. We generally have the things that we need, and we have to be creative here in theater. We don't have a plastic surgeon, so I don't do free flaps, but I get creative with rotational and advancement flaps and soft tissue coverage when we need to.
And is that Dr. Salke with another question?
That's Barry Salke. We all appreciate your service, that's for sure. But my question is, are the U.S. troops and coalition troops having to have regular surgery instead of a laparoscopic case because you don't have the equipment? I understand the local that you're not able to do that in terms of a teaching facility, but are there the U.S. troops having to have open procedures as well?
Really, the only situation where that happens, I would say, is appendectomy. We can't always rely on the air evacuation system getting them to a place where they can have that safely early enough. But actually, SP Bowers taught me this one too. If a patient can have a surgery tomorrow, they can have the surgery tomorrow in Germany or in Bagram or in some place where they can do standard of care like a cholecystectomy. But appendectomies, it was really the time when U.S. troops are getting an open surgery that I would have otherwise done laparoscopically. Fortunately, there are not too many morbidly obese U.S. troops, and we can usually do it through a fairly small incision. But most of the cholecystectomy, inguinal hernia repair work is on local tribal elders or Afghan National Army, Afghan Border Police type patients. Thank you for your question, Dr. Salke.
I think that there are no further questions, so we'll move forward. Josh, thank you very much. We really appreciate your service, and please stay safe over there.